My name is Dr. Amanda Nizam. I'm a genitourinary medical oncologist at Cleveland Clinic, and I'm joined today by Dr. Matthew Galsky from the Tisch Cancer Institute at Mount Sinai, who will discuss his oral presentation at ASCO 2024 about a subgroup analysis from the CheckMate 901 trial of gemcis-nivo versus gemcis, and he presented data on complete responders and outcomes in patients with lymph node-only disease. Welcome, Dr. Galsky.
Thank you.
Yes. So could you tell us a little bit about the overview of the CheckMate 901 trial and
Sure.
what drove this post-hoc analysis?
Absolutely. So CheckMate 901 evaluated the combination of nivolumab plus gemcis versus gemcis alone as frontline treatment for metastatic urothelial cancer, showed an improvement in overall survival, progression-free survival. The regimen's now approved in the US and Europe as frontline treatment. We previously reported that there were higher response rates with nivo-gemcis versus gemcis, and in fact there were higher complete response rates too, 20% versus 10%, and so that really prompted this current analysis to take a deeper dive at that subset of patients.
Okay, and what did you find in terms of patients who had complete response, and then specifically in those patients who had lymph node-only disease, which we know is a favorable prognostic factor in advanced urothelial carcinoma?
So we looked at several characteristics in terms of the all-comer population versus the patients who had a CR to identify whether or not there were any features associated with CRs, and what really stood out was lymph node-only metastatic disease. Over 50% of patients with CR had lymph node-only metastatic disease, and that was only 18% of patients in the overall study population. So we then focused our attention to that population for the reasons that you mentioned. We know that they do better with gemcis alone. We know they do better with immune checkpoint blockade alone. And so because of that, one can argue one way or the other. One could say, well, these are overlapping patient populations. You don't really get much more bang for your buck by giving two drugs at the same time. Or you could take it the other direction and say, these patients are exquisitely sensitive to both of these drugs. Maybe we can really change the trajectory of the illness for these patients. We thought maybe more the latter, so that's why we did this analysis, and in fact, that's what we saw.
Yeah. And very impressive findings from the lymph node-only disease, and really that was the big takeaway when these two trials were presented at ESMO 2023, the EV302 trial and the CheckMate 901 trial, is really trying to define those patients who respond and derive complete response. So we did see data from Dr. van der Heijden, subgroup data presented at ASCO GU this year, looking at by lymph node-only disease, and granted that did include patients who are carboplatin eligible as well. But in patients who have lymph node-only disease, how do you approach these patients now, where both regimens are available? Because, as you know, are we over-treating patients with lymph node-only disease with EVP?
So it's a great question, of course, and we're talking about cross-trial comparisons here, so we're going to have to make some assumptions. What we do know is that the response rate in lymph node-only metastatic disease in EV302 is about 77%. It was about 81% with gemcis-nivo. So if anything, I think we can say they're pretty comparable. The CR rate, I don't know that we know that for EV-pembro with lymph node-only metastatic disease. So that's one. The second is that one regimen's given for a fixed duration, the other, the EV, is given until progression. We know most patients don't receive it till progression, but that's the way that the regimen's delivered. And so are there a subset of patients for whom, particularly with pelvic lymph node-only metastatic disease, for whom we think maybe surgical consolidation might play a role? Can we give them a fixed duration of treatment, take them to surgery, and potentially give them adjuvant nivolumab, because that's an established paradigm, and sort of that would be continuation of the single agent nivo. I think that's a strategy that's reasonable based on the available data.
Yeah, so that'll be interesting to see, trying to optimize these outcomes for these patients who are kind of straddling the border between locally advanced and metastatic disease. So that'll be very interesting in the era to come, especially with upcoming trials of EV-pembro in the perioperative space. So what other takeaways do you have from the data you presented today?
So I would say that we have two new frontline regimens. Both of them are very active in this particular patient population, and I think we are really changing the face of this disease for some patients, regardless of which regimen is used.